Chapter 6, Organization of Care. This is perhaps the most important chapter because if a person living with diabetes is not engaged in their own care, nor supported by a proactive team, then it may be more difficult to follow the recommendations from the other chapters. I'm Dr. Maureen Clement, lead author, Clinical Assistant Professor, University of British Columbia, primary care physician and diabetologist. My co-authors include Pierre Filteau, Betty Harvey, Susie Jin, Tessa Laubscher, Geetha Mukherjee, and Diana Sharafelli. My co-authors are from various disciplines and from across Canada. Since the last guidelines, evidence continues to reinforce the importance of the interprofessional team in diabetes care, and that care should be structured, evidence-based, supported by clinical information and decision support systems. This chapter will present new information on the role of telehealth technologies. In diabetes management, a care gap exists between what is recommended and what is actually done in real-life practice. The chronic care model aims to reduce that gap by using an organizational and evidence-based approach to treating chronic disease. The chronic care model transforms an approach that is acute and reactive to one that is proactive, planned, and population-based. This slide shows the components of the expanded chronic care model, the goal of which is to link an informed and activated person living with their chronic disease, such as diabetes, with a prepared and proactive team. Evidence for improved outcomes for those practices using the chronic care model is robust. The CCM has been shown to improve A1C and LDL, as well as guideline adherence, for example, use of statins, drug and hospital expenditures, and overall mortality. The elements of the chronic care model include delivery systems design, self-management support, decision support, clinical information systems, the community, and health systems. Delivery system design means making systematic changes to primary care practices and health systems to improve the quality, efficiency, and effectiveness of patient care. An important part of which is the interprofessional team, which may include educators, nurses, registered dietitians, pharmacists, and psychological support and others working with primary care providers with input from diabetes specialists. Disease or case management has been shown to be particularly effective as it uses patient education, coaching, the ability to adjust treatment, monitoring, and care coordination. The most important member on the diabetes healthcare team is the person living with diabetes and caring for themselves on a daily basis. In turn, they ought to be surrounded by all those who help them attain their goals. Self-management support, formerly known as diabetes education, are all those activities that support the implementation and maintenance of behaviors for ongoing diabetes self-management. There has been a shift from didactic diabetes education to a patient-empowering, motivational approach, which includes problem-solving and goal-setting. For a more fulsome discussion, please see Chapter 7. Decision support is the integration of evidence-based guidelines into the flow of clinical practice. These tools and techniques can improve the decisions made by the team in patient care. They are most helpful when they are available right at the point of care. This decision support can be general in the form of education or access to specialist support, or very specific with care algorithms built into the electronic medical records or clinical flow sheets available for patient visits. One decision support tool which has proved particularly helpful is the patient care flow sheet. Examples of these flow sheets are available at guidelines.diabetes.ca. Here is an example of a patient care flow sheet, this one most adaptable to an electronic medical record system. There are also examples of those that can be used for paper charting. In general, data is collected about the type of diabetes and onset, glycemic management, including A1C targets, type of anti-hyperglycemic medication, and recording of hypoglycemic episodes. There is generally a section on the screening and management of macrovascular complications and risk factors. There is a section on microvascular complication screening and management that would include a section on chronic kidney disease, retinopathy, or neuropathy, and finally a section for patient goals, self-management, and barriers to self-management that might include topics such as preconception planning, driving guideline review, and sick day management. Helping people living with diabetes prepare for their diabetes-focused visits is also critical to improving outcomes. Patient education tools are available at guidelines.diabetes.ca. Clinical information systems help organize patient and population data to facilitate efficient and effective care. They may provide ability to develop registries and also timely reminders for providers and patients, identify relevant subpopulations for proactive care, facilitate individual patient care planning, share information with patients and providers to coordinate care or monitor performance of practice teams and care systems. Environmental factors such as food and housing security, the ability to lead an active lifestyle, as well as access to care and social support, also impact diabetes outcomes. Community partnerships should be considered as a means of obtaining better care for people living with diabetes. Tapping into community resources may improve diabetes care or lifestyle and may involve peer-led self-management support groups. Components beyond the person living with diabetes and their provider influence outcomes. Support for diabetes care at the level of the healthcare system, such as the national and provincial systems, is essential. This may involve promoting preventive care and appropriately planning resource allocation, and it may include provider incentives for achieving milestones. Telehealth, also sometimes called telemedicine or telecare, is the provision of healthcare remotely by means of a variety of telecommunication tools. This could include telephones, smartphones, mobile wireless devices, internet, or even social networking platforms. Although not a specific component of the chronic care model, it may facilitate other elements. Conferencing or education of team members may be done via telehealth, telemonitoring of healthcare data such as glucose readings, case management via telephone or internet, and telecommunication with specialists have all showed improvement in outcomes. The 5 R's is a handy mnemonic to remember the organizational interventions that improve diabetes care. Number 1, recognize. Consider diabetes risk factors for all your patients and screen appropriately for diabetes. Number 2, register. Develop a registry for all your patients with diabetes to help track care. Number 3, resource. Support self-management through the use of interprofessional teams, which could include the primary care provider, diabetes educator, dietitian, nurse, pharmacist, specialist, and self-management support, including linkage to community services. Number 4, relay. Facilitate information sharing between the person with diabetes and the healthcare team to coordinate care and timely management changes. Number 5, recall. Develop a system to remind your patients and caregivers of timely review and reassessment. Recommendations from the Organization of Diabetes Care chapter. Number 1, diabetes care should be organized around the person living with diabetes and their supports. They should be an active participant in their own care and shared care decision-making and self-manage to their full abilities. Diabetes care should be facilitated by a proactive, interprofessional team with specific training in diabetes. They should be able to provide ongoing self-management education and support and incorporate as many components as the chronic care model as possible. Number 2, the following quality improvement strategies should be used alone or in combination to reduce A1C and improve one or more of the following: blood pressure, LDL cholesterol, adherence to recommended diabetes complication screenings. These include promotion of self-management, team changes, which means adding a member to the interprofessional team, case management, patient education, facilitated relay of clinical information, electronic patient registries, patient reminders. Audit and feedback, as well as benchmarking, clinician education, clinician reminders, with or without decision support, clinical decision support systems, processes of care only and clinical outcomes when combined with feedback and case management, structured care, and multi-component quality improvement strategies. Recommendation number 3, an interprofessional team with specific training in diabetes and supported by specialist input should be integrated within the diabetes care delivery models in primary care, grade A, and specialist care settings, grade D consensus. Recommendation number 4, the role of the diabetes case manager should be enhanced in cooperation with the collaborating physician to include interventions led by a nurse, pharmacist, or registered dietitian to improve coordination of care and facilitate timely changes to diabetes management. Number 5, the following individuals should work with an interprofessional team with specialized training in these areas of diabetes as part of a collaborative shared care approach: children with diabetes, adolescents and emerging adults with type 1 diabetes as part of a structured transitional program, people living with type 1 diabetes, women with pre-existing diabetes who require preconception counseling and prenatal counseling, and women with gestational diabetes. Number 6, referral to an interprofessional team with specialized training may be considered for individuals with type 2 diabetes who are consistently not meeting cardiometabolic targets, adults with depression and diabetes for collaborative care, and in particular nurse case management for improvement in depression and glycemic control. Number 7, telehealth technologies may be used to improve self-management in underserviced communities, facilitate consultation with specialized teams as part of a shared care model, improve clinical outcomes in type 2 diabetes, including a decrease in A1C, an increase in quality of care, for example, guideline adherence, a decrease in health service use and cost, and an increase in patient satisfaction and knowledge, improvement in glycemic and cardiovascular risk factor control in type 1 and type 2 diabetes. Summary of the Organization of Diabetes Care chapter. Diabetes is a chronic disease that requires proactive, planned, and population-based care. It takes a team. Diabetes care should involve an interprofessional team working within the chronic care model. Use technology. This could include telehealth, reminder systems, EMR, registries, and these can be used to improve care. Organization of diabetes care, key messages. Diabetes care should be organized around the person living with diabetes and their supports. The person with diabetes should be an active participant in their own care and be involved in shared care decision-making and self-management to their full abilities. Facilitated by a proactive interprofessional team with training in diabetes and the ability to provide ongoing self-management education and support. Diabetes care should be organized within the context of the expanded chronic care model and delivered using as many of the components of the model as possible. In particular, self-management education and support, interprofessional team-based care with expansion of professional roles, collaboration with the primary care provider, and monitoring with medication adjustment and case management. Diabetes care should be structured, evidence-based, and supported by clinical information and decision support systems that include patient registries, clinician and patient reminders, facilitated relay of information, audits, feedback, and benchmarking. Any of the above strategies may be facilitated with telehealth technologies. Key messages for people living with diabetes. Know the members of your diabetes team and stay connected with them. Remember, you are the most important member of the diabetes team. Be prepared to learn how to care for your diabetes on a daily basis. Also, be prepared to share in decision-making regarding how you will care for your diabetes and health. Prepare for visits with your healthcare team. Have a laboratory test done prior to the visit so the results will be available to review at your diabetes focus visit. Be prepared to set and update your personal goals for caring for your diabetes and health. Be prepared to share any issues that may affect your ability to care for your diabetes on a daily basis, including any fears or anxieties you may have. Bring your medication bottles or an up-to-date medication list, including non-prescription drugs and supplements. Also, bring your glucose meter and insulin pen device if you use one. Bring or upload your most recent glucose monitoring results, as well as other health behavior records, such as food or an exercise diary, as well as a healthcare diary in which you have recorded important health events, such as visits to other healthcare providers, surgeries, illnesses, or vaccinations. Share the information you learn during your visits with your diabetes healthcare team with all of your healthcare providers and diabetes team members. And finally, if travel distance or time is a barrier to your care, ask your team about telehealth, using telephone or web-based or virtual visits for diabetes support and care. The full guidelines, interactive tools, and other useful resources can be accessed on the Guidelines website at guidelines.diabetes.ca. This information is also accessible on the Diabetes Canada app. This is available at the App Store or Google Play.